Well, let's see how this works. Uh, for me, it's evening, so good evening, everybody. Um, and it's a pleasure to contribute to this session on mechanical ventilation. I'm sorry I can't be there with you. I'm sure the weather would be a lot better. It's cool and rainy here in Boston today. Um, I very much appreciated Steve's talk. It fits in well. I no longer make big distinctions between um, high flow and non-invasive ventilation, even though they have major differences that I'll talk about. But we often use them in tandem, and we thought that it would make sense for Steve to go first, even though NIV has been around longer than high flow, because in the clinic or in the ICU, we generally move from high flow to non-invasive ventilation. We sometimes alternate back and forth depending on the situation. Um, but if I could have the next slide, please. These are my disclosures. Actually, I do consult for Telesair as well that Steve is working for, so I neglected to put that there. And if I could have my next slide. So what I'd like to do is continue where Steve left off about the physiologic basis. I've been asked to talk a little bit about the evidence base. I'm going to mention the guidelines, as Steve did, in relation to high flow, and a few words about epidemiology. I don't think it's me. Okay, it's gone. Okay. I hope it doesn't come back this time. In any case, the fundamental physiology of NIV in COPD and in a number of different conditions was explored by Laurent Brochard in this New England Journal article in 1991. And Laurent was one of the pioneers in this area, and he was using essentially a homemade pressure support ventilator in a small group of COPD patients, 12 with severe COPD. And on the left, you can see some tracings in the top panel. It was airway pressure, and you can see what you would expect, and someone is spontaneously breathing on the left, and then getting intermittent pressure support breaths on the right. Then having trouble reading this thing because it prints very small. I believe we're looking at transdiaphragmatic pressure as the second row, and you can see big dips in people, someone spontaneously breathing, and then much smaller dips in someone being assisted, indicating a significant reduction in diaphragm work. And then we can see the EMG signals, the third row, again, a significant drop in the EMG footprint. And then airflow at the bottom there, um, not terribly different between the two conditions, but what's notable is that the rate is much lower. And then if you calculate out uh, some of the findings on the tracings there, the respiratory rate consistently goes down significantly. In the upper left, the tidal volume is increased, the minute volume goes up, and hence augmentation of ventilation, reduction in CO2, and the transdiaphragmatic pressure goes down. So we are augmenting tidal volume, we are reducing work of breathing as indicated by transdiaphragmatic pressure. Next slide. It's important to point out, by the way, that Brochard was not administering PEEP in this experiment. It was just pressure support. My slide is not advancing. Is that possible to advance it? Oh, here we go. Okay, we're missing the figure. Maybe we could advance it a little more. All right. Well, while we're waiting, I will just mention that what you should be seeing is a slide I obtained from a paper by Lorenzo Appendini, who is an Italian pulmonologist, and did a study on patients subacutely ill with COPD, studied them a day or two after they were admitted with an acute exacerbation, and had them on non-invasive ventilation with or without PEEP. And he studied them breathing spontaneously when the transdiaphragmatic pressure was maximal, and then added a CPAP of 5 centimeters of water and found a reduction in work of breathing by about 25%. He put them on a pressure support of 10 without PEEP and found about a 75% reduction. And when he added pressure support with PEEP, he got a 50% reduction. So we can move on to our next slide, and I can pray that the figure will come up on that one. Okay, well, so once again, our figure is not coming up, but what this demonstrates is how adding PEEP reduces the work of breathing, the transdiaphragmatic pressure, and this is because if you have auto PEEP, as you likely do in patients with severe COPD, especially during exacerbations, you are left with a positive pressure in your alveoli at end expiration. You don't come down to equilibration with atmospheric pressure. And in order to get air to move in for your next breath, you have to lower the intrathoracic pressure below atmospheric, and you must exert a significant amount of work to do so, depending on how much auto PEEP you have. And if you apply a positive pressure, CPAP will work for this. You reduce the amount of reduction in intrathoracic pressure by the amount of CPAP you are applying. Hence, you reduce the inspiratory threshold to initiate the breath, which reduces your transdiaphragmatic pressure and the work. And you also can trigger more easily if you have CPAP on board. So the benefits of non-invasive ventilation in acute COPD compared to conventional treatment are that it more rapidly improves dyspnea, more rapidly reduces respiratory rate and heart rate and breathing effort, reduces CO2, improves oxygenation, lowers intubation rate by in the range of 65%, depending on the study, a significant reduction in mortality, and less time in the hospital. And these are things that have been shown in a number of meta-analyses. I'm quoting one by Kwan in Chest of '08. And we also know that patients with COPD in different circumstances benefit from NIV, including difficult weaning. Stefano Nava showed 25 years ago that in patients with COPD in his respiratory unit who were having difficulty weaning from mechanical ventilation, even before they met standard extubation criteria, he could extubate them, put them on non-invasive ventilation, and stabilize them, get them extubated sooner, and avoid a lot of the complications of prolonged intubation. And this has been replicated by others, such as Miguel Ferrer of Spain. NIV in patients with COPD who have pneumonias reduce the mortality compared to standard oxygen and reduce intubation rate in those patients. Extubation failure, do not intubate status, postoperative respiratory failure are all situations where non-invasive ventilation has had positive evidence. In do not intubate patients, we probably lean more toward high flow these days because it's much more comfortable on average for patients. Another major indication for non-invasive ventilation is for acute pulmonary edema. There is a strong physiologic rationale, but it's a little different than with COPD. In patients with acute cardiogenic pulmonary edema, there is flooding of alveoli that interferes with oxygenation and reduces lung compliance. And CPAP in the range of 7.5 to 10 centimeters of water pressure reverses these effects, re-expanding the lung, increasing the FRC, allowing drainage of fluid from flooded alveoli, thus improving oxygenation and compliance. And there's also an afterload reducing effect of the increased intrathoracic pressure, which can improve cardiac function. If you add pressure support to CPAP under these circumstances, in which case you essentially have BiPAP, you actually don't improve the outcomes. And there are multiple randomized controlled trials that have demonstrated this, and here is a meta-analysis that was published in the single digits of the new millennium. And what it shows, in essence, is that with regard to reducing the need for endotracheal intubation and reducing mortality, whether you use CPAP, which would move the forest plot to the left, or you use essentially BiPAP, pressure support plus PEEP, in which case you would move to the right, the sum signal for both of these is right on the line of equipoise. So both of them are equally efficacious in achieving these outcomes. It is the case, and some of our studies have shown this, that the reduction in respiratory rate and improvement in oxygenation is a little quicker if you add pressure support, but you end up in the same place. So this evidence led to a large increase in the use of non-invasive ventilation over the decade 2000 to 2010 in the United States. And this is from an article by Chandra et al., published in the Blue Journal in 2012, using the inpatient national database in the U.S., looking at a total of over 7 million COPD admissions. So they have very large ends here. And what's interesting about this is there's a steady increase in the use of non-invasive ventilation during this decade, a steady decrease in invasive mechanical ventilation for these COPD patients, And in 2007, there was a crossover. So in some of our studies in Massachusetts show that around that time, we went from a minority of applications in COPD patients to about 80% as the initial mode of mechanical ventilation. And this is from the same study, but this is the overall mortality rate, and it is steadily going down as we use more non-invasive ventilation. There was this one subgroup of patients who started on NIV and then ended up getting intubated, and their mortality rate did not come down. In fact, there might have been a little trend to go up, and this raises the concern of overzealous use of non-invasive ventilation in a small subgroup of patients who are going to fail NIV, and it underlines the importance of not waiting too long to intubate a patient who is failing NIV to avert a respiratory crisis. Many of you probably have seen the ERS ATS clinical practice guideline that was published in ERG 2017. I was one of the task force members of the steering committee for this, and we came up with a number of recommendations, and the number of little pluses here in the middle correspond with the strength of the recommendation. So hypercapnic respiratory failure due to a COPD exacerbation is the strongest recommendation for use of non-invasive ventilation. Cardiogenic pulmonary edema is right up there with 3 pluses instead of 4. We made no recommendation for acute asthma, for de novo respiratory failure, meaning hypoxemic respiratory failure, acute hypoxemic respiratory failure. And we also made no recommendation for a pandemic viral illness. And of course, we had a pandemic coming at us in tsunami fashion just a few years later. And we've heard from Steve that high flow has performed reasonably well under certain circumstances in people with hypoxemic respiratory failure. And also, as I pointed out, palliative care, we also used it a lot during our pandemic, as he pointed out, but I'll show you a little bit of evidence from that. And I don't think it's convincing right now that we have a clear winner when it comes to hypoxemic respiratory failure. In relation to hypoxemic respiratory failure, there are concerns about using non-invasive ventilation. Some of those concerns were raised by the LungSafe study, this large observational multinational ARDS study. 506 of the 2,800 patients enrolled, or 18%, were treated with NIV, and the NIV failure rate in mild ARS was only 22%. In moderate ARDS, it was 42%, and in severe, it was 47%. But the thing that was disturbing was that if your PF ratio was less than 150, the mortality rate, if you started out on NIV, was 36%. If you were intubated right away, it was 25%. So concern was raised that in these more severe patients, you should have a very low threshold if you want to even give NIV a try for moving on to invasive, or maybe there are a number of patients you just put on or you intubate right away. And one other concern in parallel that's been raised is that people on non-invasive ventilation with hypoxemic respiratory failure and a lot of respiratory drive are taking large tidal volumes that may exceed the safety level and contribute to further lung injury, ventilator-induced lung injury. So why is NIV so challenging? Well, those are some of the problems, but also when people have severe OT defects, they need more PEEP in general. The more PEEP, the more leakage around masks, the more difficult it is to synchronize. They have these high volumes, high minute volumes, and they also have underlying diseases that often progress, underlying sepsis, multi-organ disease, syndrome, and they often are deteriorating. So and they're in for long hauls, and non-invasive ventilation is really not good for supporting people acutely ill for long periods of time. Acute cardiogenic pulmonary edema on average is no more than a few hours, and COPD maybe a couple days, but they generally can get off fairly quickly as you treat their underlying disease. So what about the role in moderate ARDS? What's the role of the interface? And you've already seen data from the Florali trial that Steve mentioned. J.P. Fratt was the first author, published in New England Journal in 2015. And this showed the benefit of high flow with a significantly greater reduction in mortality at 90 days with high flow as compared to mask non-invasive ventilation or standard oxygen. And then this is pre-pandemic, by the way. And then the findings with the helmet in patients with NIV from University of Chicago, where they found that the intubation rate with the helmet was 18% in this group of 83 patients randomized to one or the other. The failure rate if you used a full face mask was 62%, and there was a 90-day mortality reduction to 34% with the helmet versus 56%. So this suggested, as Steve said, that high flow may be preferred in ICUs for use in hypoxemic respiratory failure. And in fact, in Fratt's unit in France, they essentially don't use NIV anymore. Now, these studies have not been replicated, and there are methodologic issues with both of them. In Fratt's study, he targeted 7 to 10 milliliters per kilogram as a tidal volume and ended up with 9.2. And then one of his explanations for why there was a higher failure rate was that the tidal volumes were too high. Of course, those were selected by the authors as part of their standard methodology. So maybe they were setting NIV up for failure. In the helmet study, it was unblinded, a single center study, relatively small numbers, and they used different ventilators, they used different ventilator settings, and so this has not been replicated either. Here is the helmet. It is the C-long helmet that was designed for use in bariatric chambers. We bought several dozen of them at the start of the pandemic based on the findings of the University of Chicago study, and they worked very poorly. There's that blue ring clips on, and it doesn't hold very well, and it pops off if you use a sufficient amount of pressure. And we had to use duct tape to hold it together, so not a real high quality device. Now, when you're comparing non-invasive ventilation to high flow, as I mentioned, physiologically there are some major differences, and I see NIV as being about the pressure. You know, we generally are using some form of pressure support ventilation with it. So we pick a pressure support level, which in BiPAP settings is the difference between the inspiratory pressure and the expiratory pressure. And we pick a backup rate, and depending on the patient's spontaneous rate, we cycle between the target pressure, the expiratory pressure, and then the added inspiratory pressure. And during inspiration, there's a substantial increase in pressure depending on exactly what settings we select. With high flow, it's about the flow. We select a flow, and based on the rate, as Steve pointed out, we get about 1 centimeter water pressure for each 10 liters per minute flow, and this assumes the mouth is closed. But here, with the patient with their mouth closed, we're seeing that during inspiration the pressure dips, and then it peaks at early expiration when expiratory pressures are highest, and the highs entering flows impose an impedance on the expiratory flow, and as expiratory flow diminishes, so does the expiratory pressure, and then during inspiration, it dips down, and depending on how much inspiratory force you apply, you can actually pull these pressures down to sub-zero. So if you're thinking about someone with COPD whose improvement is related, as shown by Appendini, to the pressures you're applying, you need to be very careful if you want to use high flow. There are some studies that have looked at the use of high flow in COPD, but I would argue that if you have a severe exacerbation and you need those pressures, there are advantages to NIV, even though a couple of these studies have shown non-inferiority of high flow. Now, I will very quickly just mention these studies. Up here, I'm listing the Florali study, the helmet study I showed you, and then a meta-analysis looking at these things. And what I'm showing is that, yes, intubation was improved. Yes, mortality was improved in both of those studies, as I showed you, and then you put them together in a meta-analysis, and not surprisingly, you get pretty much the same result. But during COVID, there were quite a number of studies that were published. We did some work on this. We actually have not published our study yet, but one of the early studies came out of Italy, which was hit by the pandemic earlier than the US, and they are experts at the use of the helmet. They've been doing it for decades. They've published many, many studies. They have never shown results like that came out of University of Chicago, and they found that whether you use high flow, the helmet, or the mask NIV, there was no reduction in intubation with one versus the other, no mortality. Now, it's important to remember that this was a pre-ICU study. If the patients needed to go into the ICU, then they were not part of this database. In Paris, they compared high flow to patients who did not get high flow in 4 units, and they found an intubation reduction, but no difference in mortality. In Italy, Greco in JAMA showed that helmet CPAP reduced intubation compared to high flow, but no reduction in mortality. Perkins, this was the UK recovery study, which was a multi-platform study. It was the one that showed that dexamethasone was effective in very sick COVID patients. But because of the multi-platforms, they were doing a bunch of different comparisons. It was a modified adaptive design, which really is not intuitive. So they had a group of CPAP and standard oxygen, where the CPAP performed a little bit better in avoiding intubation. But they also found that high flow and standard oxygen were equivalent, but high flow not superior to standard oxygen. So this is in total conflict with the Florali study. So here they found that intubation was reduced, no difference in mortality. This was Ospina is a study out of Columbia, showed high flow is better than standard oxygen, consistent with what we saw with Florali, but this study did not allow any crossovers. And this would make it very hard to get through an IRB or perform in the US, because physicians have a feeling that high flow and NIV are ways of escalating people who are not doing well on standard O2. And so, not surprisingly, they showed a reduction in intubations, because your only choice if your patient on standard oxygen got in trouble was to intubate them. And again, no difference in mortality. And then the CREAMY study allowed crossovers and showed no difference. And then the Arabi study is a Saudi Arabian study. I was on the DSMB for this one. I thought it was a very well done study, but their control group was a mixture of different non-helmet modes that were up to the discretion of the clinicians. So a very mixed bag in the control group, but they found no reduction in intubation and no change in mortality. So what we're seeing here is results that are simply not holding up. And I think it raises questions about the Florali study. Of course, we're looking at COVID versus pre-COVID, but I certainly would have thought that some of these would have shown more of a signal. Nobody has shown a reduction in mortality in any of these studies compared to these pre-pandemic studies. So to summarize, non-invasive ventilation for acute respiratory failure it has a strong physiologic and clinical evidence base to support use in hypercapnic respiratory failure and COPD, cardiogenic pulmonary edema. There are a number of other indications as per our guideline where use is appropriate. But what to do with hypoxemic respiratory failure is still controversial. And I think the more recent data from the pandemic, and we'll see what happens post-pandemic, but I have questions about whether high flow is really that much better. It's still very difficult to manage these patients non-invasively. I will stop there and be happy to entertain questions.